2024 to 2027, one of our core objectives has been to bring to the attention of professionals, regulatory authorities, and policymakers the crucial role of breastfeeding and health promotion during the first 1,000 days of life, from pregnancy to early infancy, in shaping the health trajectories of future generations. While there is a strong and growing body of scientific evidence supporting community-based actions in the earliest stages of life, babies and their families and caregivers not always receive proportional visibility within broader policy frameworks. Strengthening the focus on babies, young children, and their families within strategic planning processes is therefore essential. The literature is clear. Investing in the earliest stages of life generates sustained health, social, and economic benefits across the life course. Today, we are honored to host distinguished speakers whom I would really like to thank in advance for their valuable contribution. And without taking any further time, I am pleased to hand over to our colleague, Hanne Bliskas, who will moderate today's webinar.
Hello, everyone, and a warm welcome to all of you. My name is Hanne Bliskas, and I will be the moderator of today. I work at the Norwegian Directorate of Health in Norway. We are delighted to welcome our distinguished speakers today who will share their valuable knowledge and insights with us. But before we begin, just a brief note on the format for today. If you have any questions during the presentations, please feel free to type them into the chat at any time. I will bring selected questions to the speakers after the final presentation, if time allows. And it's now my pleasure to introduce our first speaker today, Nigel Rowlands. Nigel Rowlands is a pediatrician and a professor at Queen's University, Belfast. He has worked for many years in WHO and was a lead author of articles in both the 2016 and 2023 Lancet series on breastfeeding. Today, he will give us an update on the evidence of breastfeeding for the prevention of non-communicable diseases in both mother and child. The floor is yours, Nigel. Nigel, we can't hear you. I think you're muted.
Great. Thanks indeed for the invitation and the opportunity to share with you. As mentioned, I worked at WHO for a number of years and now presently Professor of Maternal Child Health at Queen's University, Belfast. Just for disclosures, I receive and have received funding for technical support to research projects about stunting in Rwanda, for providing technical support to the Public Health Agency in Ireland on promoting breastfeeding, and also for developing teaching modules. But my views, what I'm going to share today, are my own personal views. So in the next 13 minutes or so, I want to touch on three issues. First of all, how evidence is classified when any guideline is actually developed. Specifically then, the evidence related to breastfeeding and non-communicable diseases for both children and mothers. And then an important issue is it plausible, biologically plausible, that breastfeeding can actually reduce the risk of non-communicable diseases? And this is an important point for us to consider. So, as mentioned, I worked at WHO, and this is the building in Geneva, and it has 6 core functions, and one of them is setting norms and standards, and that's the UN language for setting guidelines. WHO has an entire process for developing guidelines, and it has a handbook that describes how evidence is interpreted and used when developing any recommendation. Central to this is a process called GRADE, which is about how evidence is rated and the quality assessed. This, I'm going to give a very reduced version of this, but one of the fundamentals is understanding the quality of the evidence. And because this underpins the confidence that anyone ever has in terms of the recommendation and how much to do with that. At the heart of the quality of evidence is understanding different types of studies. And so people will maybe be aware that the gold standard is often called a randomized controlled trial. For breastfeeding, we generally cannot do that because it would be unethical. And therefore, observational studies and cohort studies are where the majority of the evidence comes from. But we don't look at only one observational or one randomized trial. When developing any guideline, all of the published evidence is collated, collected, and analysed. And that's what we call a systematic review. And so we are then able to see what is the full breadth of evidence underpinning any recommendation. But in addition to a specific estimate or a percentage effect, there is also consideration to the number of people involved in any study. That's what we would call the size of the study. Whether there is consistency of the finding between different studies, or whether there are mixed findings depending on the setting, whether there is what we call a dose-related effect. If you get more of an exposure, whether you have more of an outcome, and we will see that a little bit later. And then to consider, is this really possible that something could have this type of biological outcome? So with that, we're going to think a little bit about three particular aspects of non-communicable disease in children: childhood overweight and obesity, metabolic illness, insulin resistance and diabetes, and then also cardiovascular disease, which includes both coronary heart disease and brain cerebrovascular disease later in life. We're going to think about the mother, the risks of breast cancer, ovarian cancer, type 2 diabetes after a pregnancy, and also a mother's cardiovascular risk disease, coronary and cerebral, years after having been pregnant. We're not going to look at postpartum depression, but there is some interesting data today on that. But what I really want to emphasize is to look at the entire story, look at the trend and the overall patterns of effect rather than the exact numbers and percentages, because the story is actually in the overall and consistent effects of breastfeeding rather than a specific percentage. So when we look at the evidence on the impact of breastfeeding on childhood overweight and obesity, there were systematic reviews conducted in 2015 in advance of the first breastfeeding series in The Lancet in 2016. And the systematic review showed a 26% risk reduction whenever 105 studies were evaluated. But I would prefer for us to look at the outcomes whenever the analyses were restricted just to 11 high quality studies. And in that there was a 13% reduction. And this is probably a better estimate of the impact of breastfeeding on later overweight and obesity. So it has a 13% risk reduction for that. I should add that since 2015, there have been several systematic reviews and other analyses, and every one of them has showed a similar magnitude of risk reduction since then. When we look a little bit more broadly, we see that breastfeeding as a child does not appear to have any impact on blood pressure, systolic or diastolic, nor on cholesterol. But it does, breastfeeding as a child does have a significant, statistically significant risk reduction on diabetes type 2. So a 35% risk reduction if a child was breastfed. When we think about cardiovascular disease, when that child reaches adult life, we have a specific population cohort study of about 300,000. There isn't a single systematic review, but this is the largest and most recent study. And here we see that there is a small percentage reduction in cardiovascular disease, but there is about a 9% reduction in cardiovascular disease-related deaths, a 7% reduction in myocardial infarctions, and a 19% reduction in myocardial infarction-related deaths. In any public health intervention, if you were getting a 10% reduction for something that is very common, that would be a very significant contribution. Whenever we look at the evidence for reduction of maternal-related non-communicable diseases, again in 2015, the systematic review showed a 22% risk reduction if a woman ever breastfed. But whenever the higher quality studies were looked at only, then the effect was still significant, statistically significant, with an 8% reduction in that risk of maternal breast cancer. And here we have a dose-related effect. The longer a woman breastfeeds, the lower the risk of breast cancer. That same systematic review looked at ovarian cancer, and we see from 41 estimates that there was a 30% risk reduction of ovarian cancer among women who breastfed. And since 2015, there have been subsequent systematic reviews, again consolidating all the available evidence, and they all demonstrate a similar risk reduction. When we think about maternal diabetes, the most recent systematic review was conducted in 2021, and here we see a 27% lower risk of type 2 diabetes amongst mothers who breastfeed. But when a woman is pregnant, some women develop diabetes during pregnancy, and this is called gestational diabetes. And these women have an especially high risk of developing diabetes in the years after pregnancy. And what we see is that breastfeeding has a even significantly larger effect, and it is more protection for these specific women. So with women who have had gestational diabetes, there's a 34% reduction if they breastfeed. And again, we see a dose-related effect. If a woman breastfeeds for longer, then the lower the risk. Since 2021, there have been additional individual studies and more systematic reviews. In this one study in the UK, this was only amongst women who had had gestational diabetes. They turned the information the other way round. Instead of saying the percentage reduction, they say that if a woman who has had gestational diabetes in pregnancy and she does not breastfeed, then there is a 76% increased risk of type 2 diabetes in the years that follow. And then the most recent systematic review is the same, very similar to the earlier one in 2021, where women with gestational diabetes, there is about a 36% reduction in the risk of type 2 diabetes in the years that continue. And they also reported no effect of breastfeeding on maternal osteoporosis. Lastly, looking at the risk of cardiovascular disease in women who have breastfed. And here we see one study from China, and I'll show you a systematic review in a moment. But this was a prospective study where they had 300,000 women recruited and they were followed for 8 years. This was published in the Journal of the American Heart Association. And when they compared women who had been pregnant and had a child and had breastfed, compared with those mothers who had a child but never breastfed, there was a 12% reduction for major heart and stroke disease, 9% reduction just on coronary heart disease, and 8% risk reduction for strokes, and a 12% reduction in a specific type of stroke called ischemic stroke. So it's around about a 10% reduction in each of these cardiovascular diseases. And again, there was a dose-related effect. The longer the woman would breastfeed, the lower the risk. Then the most recent systematic review was also again published in the the Journal of the American Heart Association fairly recently. And here they were looking at 8 studies that looked at the outcomes in over 1 million women. And again, you see something very consistent: 11, 14, 12, 17% risk reduction for cardiovascular disease, coronary heart disease, strokes, and fatalities related to cardiovascular disease. And again, there was a dose-related effect. The longer the breastfeeding, the lower the risk. So there's quite a consistent story in terms of the metabolic impact of breastfeeding on outcomes in both children and in mothers. And that really raises the question, is it biologically plausible that breastfeeding can result in these outcomes? And the answer, without having very much time to go into detail, is yes. And I'm going to give you 1 or 2 points only. One of the things that we are learning about, and we don't actually have the true mechanism, we don't know all the answers, but we are starting to understand more. We are all aware about the human gut microbiome, and that the microbiome of children who were born vaginally or by C-section, those who are breastfed or formula fed, is profoundly influenced in the first weeks and months of life. And the microbiome has an impact not just only immediately, but for years and years. We cannot, as I mentioned earlier, randomize some children to breastfeeding or others to formula feeding, but these are studies that have been done in macaque monkeys. And here they looked at macaques that were formula fed and those that were given maternal milk. Now, these colors all represent things to do with the immune system. But you can just tell from the color, the differences on the left and on the right, there's a profound difference in the immune systems of children who were breastfed and formula fed. And we're learning many, many things about breastfeeding, about carbohydrates, genes, and so on. And the sum total of all this is that breast milk and all the things is much, much more than simply the combination of synthetic ingredients. And so in summary, what I would call the big story is that there is a very consistent and significant body of evidence demonstrating protection of breastfeeding on non-communicable diseases of children, in mothers. The quality of evidence is what we would call moderate. There is biological plausibility, and therefore we can, I think, with confidence say that breastfeeding and support for breastfeeding are really important and effective interventions to reduce non-communicable diseases and related mortality. Thanks very much.
Thank you very much for that insightful presentation, Nigel. Now let's move on to our second presentation of today. Our next speaker is Julianne Williams. Julianne Williams is a technical officer in the Division of Prevention and Health Promotion at the Regional Office for Europe. She works with the 53 member states of the WHO European region to support policies related to nutrition promotion, obesity prevention and management, and prevention and control of non-communicable diseases in emergencies. Today, she will present strategies to protect, promote, and support breastfeeding in Europe.
Great. Thank you so much for the introduction, and it's just a delight to be here today, so thank you. I really appreciated the overview that Professor Rollins gave about the associations between breastfeeding and non-communicable diseases, and how breastfeeding can be protective not only for babies, but also for mothers. As a reminder, NCDs account for 90% of all deaths in the region. And we often discuss it. This gives the global burden of disease study results, where we often discuss diet, tobacco, and alcohol as the NCD risk factors. And today we'll be talking about the very first risk factor, some could say, how we feed our babies. When we are thinking about strategies to promote breastfeeding, we often take the big picture. So if NCDs account for 90% of deaths, breastfeeding can be an important way to reach some of these global targets, which we have for 2030. And I'd like to focus specifically on the one on the far left in the top. So our goal is to have a 1/3 reduction in the overall mortality from non-communicable diseases. And then on just over 3 to the right, you'll see this other relevant goal from Professor Rollins's presentation, to halt the rise in diabetes and obesity. And anecdotally, we see obesity and overweight rising in almost every country of our 53 countries of the WHO European region. So breastfeeding has another important role for helping us reach these targets. A reminder of the WHO recommendations. So WHO recommends that we initiate breastfeeding within the first hour of life, and then exclusive breastfeeding on demand, so when the baby requires it, for the first 6 months of life, followed by nutritionally adequate, safe, complementary foods, and continued breastfeeding for 2 years and beyond. And there are a number of resolutions from the decision-making body of the World Health Organization, the World Health Assembly, which outline these recommendations and actions. And I've listed those here. And globally, the goal is that we can increase the rate of babies who are exclusively breastfed for their first 6 months of life to at least 60%. Adding our own regional perspective from the WHO European region to Professor Rollins's presentation, we have our own data corroborating that relationship between breastfeeding and obesity. From the WHO European Child Obesity Surveillance Initiative, we've done some analyses of this, also showing that children who are never breastfed have a much higher risk of obesity. And this has been one of our advocacy tools. Later in this presentation, I'm going to talk about the importance of monitoring of breastfeeding as an advocacy tool. This is a slide which actually needs to be updated, showing just the huge variation of exclusive breastfeeding, either under or at 6 months in the WHO European region. To summarize, of the 6 WHO European regions, the WHO European region is the lowest for exclusive breastfeeding rates at 6 months of age, according to and that's a consistent finding with the Global Breastfeeding Scorecard. So even though we have some of the best research in the world coming from our region on the importance of breastfeeding, we have the lowest levels. And as we were reminded in the introduction, breastfeeding is a best buy. So it's one of our cost-effective interventions for reducing non-communicable diseases. And it's part of what we advocate when we talk about a life course approach to the prevention and control of non-communicable diseases. So thinking about the prevention of NCDs, even at the preconception period, through infancy, childhood, and adolescence, through to adulthood and older adults. And as we can think about the policy levers that we have to promote breastfeeding through these various stages of life, we can think about things like the health system at the time that a baby is born. We can think about workplace interventions, paid maternity leave, and I'll go through some of those strategies in the subsequent slides. Just as the WHO European region has some of the lowest rates of exclusive breastfeeding, we also have a lot of work to be doing on implementing policies to protect, promote, and support optimal breastfeeding practices. So from the WHO NCD Progress Monitor, you'll see here on this far right, we have very low implementation of the recommended policies to support these. So how do we create environments to support breastfeeding? To summarize, we have the International Code of Marketing of Breast Milk Substitutes. I've put a QR code here to the WHO fact sheet, which summarizes these things nicely. And really, this focuses the code focuses on the role of governments to restrict the marketing of formula, bottles and teats, provision of free sampling, the advertising to the public, and conflict of interest sponsorship, particularly with healthcare workers. The second policy we often talk about is the Baby-Friendly Hospital Initiative, the 10 steps, and I'll summarize that in the next slide. Some of those protocols related to skin-to-skin contact, rooming in, avoiding free formula, and training for maternity staff. Additionally, it's important that we think about maternity protection through labor laws. So having paid maternity leave, paid breastfeeding breaks for the mothers who are returning to work, job protection and non-discrimination for breastfeeding mothers, and the important work of the health system. So really integrating breastfeeding counseling as part of that standard of care, not only within the hospital, but following discharge through community support and other means. And importantly, in our region, which is home to some emergencies lately, including the war in Ukraine and the recent earthquake in Turkey, we're aware of just how important it is that national plans can address infant feeding and emergencies. So ensuring the protection of breastfeeding when crises hit. So this is a slide which just gives a nice summary of the 10 steps to successful breastfeeding. This is one area where in the regional office, we've collaborated with our colleagues in headquarters to provide training to maternity staff, for example, on implementing these various hospital policies, staff competencies, antenatal care, care right after birth, and beyond. And crucially, one area where there needs to be additional work in our region is the monitoring systems. There was a paper in 2016, and this pointed out just this problem of how there's an unusual situation with our data availability for breastfeeding patterns, and that's that in high-income countries, such as those that are often found in the European region, we don't have very good data. And so it becomes very difficult when we're trying to define the problem, when we're trying to look at trends over time, when we're trying to advocate for further protections on breastfeeding. And an example of that is here. This figure shows a map, and you'll see the WHO European region here. And those coral pink areas are just where we don't have data on children who have received any breast milk. So this is consistently a barrier for our advocacy efforts. Also relevant in our region and globally is just the continued inappropriate marketing of breast milk substitutes, which is undermining our recommendations for exclusive breastfeeding. And I've put the QR code here to Professor Rollins's paper on this topic. Global sales of breast milk substitutes in 2014, as he says, was around $45 billion. So we are home in the WHO European region to many of these companies that are developing these products that undermine breastfeeding, and this is another barrier which we have to work against, particularly in the digital age, where the marketing strategies to reach mothers and families are very pervasive, they're very effective. And one of the areas where we've been working in the WHO European region is to capture examples of those digital marketing tactics in order to shed light on what is happening and then find ways to address those. So I've put here in the slides a few other relevant resources related. I'll just highlight a few. I think I have 30 more seconds left. So I think for the Baby Friendly Hospital Initiative, there's a monitoring manual, which I'd like to point to. Additionally, here on the right, we have worked with experts in breastfeeding to develop a model law on sort of the regulatory frameworks for ending inappropriate marketing of breast milk substitutes and foods for infants and young children. And the link for that is just right there. So thanks again for the opportunity to present today, and looking forward to taking any questions in the chat as needed. Thank you.
Thank you so much, Julianne, and for sharing this overview of all this important work that is done. There are some comments in the chat about the QR codes in the presentation that they don't work. So I don't know if you're able to share QR codes maybe in the chat.
Yeah, sure. Sorry about
later.
that. I'll put the URLs directly in there. Sorry about that. Thank you.
Thank you so much for the wonderful presentation. Our next speaker is Patty Randall. Patty Randall is the Policy Director of the non-governmental organization Baby Milk Action and a member of IBFEN's Global Council. She has for many years been working for effective implementation of the International Code of Marketing of Breast Milk Substitutes. In 2020, she received Order of the British Empire from Queen Elizabeth for her services to infant nutrition. Today, she will give us an overview of the marketing and regulation of breast milk substitutes in Europe. The floor is yours, Patty. Let's see. Patty, are you able to put your presentation in presentation mode? And also, we don't have sound.
Excellent. Okay, sorry. Can you see it now? You can see it now?
Yes.
Excellent.
We see it very well.
Thank you. Okay, so let me just do the first slide I want to come to is, and thank you very much, Nigel and Julianne. It's really helped. That's really good that I can just get on with this. I want to start with this slide, Gabriel Palmer, who brought me into this whole issue in 1980. And she wrote this amazing book, The Politics of Breastfeeding. All over the world, women are impeded from protecting their own and their baby's health and often survival because of factors beyond their control. We have to remember this because I think we sometimes talk about breastfeeding and completely forget the pressures that are on parents and in the worlds that we live in, that they don't get the support they need, they don't get the maternity benefits, they don't get everything, and everything's against them. So IBFAN is I'll just put that in here. We strongly support the sovereign right of all women to decide how they feed their children. And in fact, if a woman doesn't want to breastfeed, that is her decision, and nobody in IBFAN would be against it. Our work is entirely focused on removing harmful practices that sabotage breastfeeding, the cornerstone of child survival. So we started in 1979, but even before that, actually. The baby food market was built on trust and dependency. And here you have a picture in South Africa from the 70s where the milk nurses, the famous milk nurses, called in by a hospital to look after the babies, and of course were teaching the mothers how to bottle feed. This same trust issue, I put that in now. This is December 25, a US company, By Heart, internet, all over the internet, because it only does internet, claims its formulas are filled with ingredients backed by breast milk science in every scoop, and that they've undergone rigorous testing going above and beyond what is required. That's not the actual tin, that's an AI version that we did. But really, literally, and this company has been found to have botulism in the formula. So it just shows you. I won't have time to go into the history, but this is a quick slide to show you that the code that we talk about was formed as a result of civil society outrage. And it was sustained outrage about the commerciogenic malnutrition that we were unaware of before people like Derek Jelliff and other fantastic pediatricians pointed it out. So I'll go here. This US actually played an important role in the formation of the code. And here we have Senator Edward Kennedy defending the right to boycott. It's really, really lovely to see this half-hour film. If you have, it's on YouTube and you can see it. So the code was the first consumer protection tool of its kind. 20 resolutions have been passed, probably 22, and these resolutions are not yet in EU law. The EU only has the code. It never refers to the resolutions, and that's something we need to change. In fact, there are 144 countries that have laws. Many of them are partially incorporating the code, but it's 144. And the latest, every 2 years, WHO, UNICEF, and IFAN do biennial reports showing the impact of the code in implementation and monitoring on the duration of breastfeeding. This latest one, 2026, which I can't talk about because that's not published till May, but that will clearly show that exclusive breastfeeding rates in the first 6 months are more than twice as high in countries substantially aligned with the code relative to countries with no code legislation. So really, it's very important to do this. And I think sometimes the companies behave as if it doesn't really matter, as long as they promote breastfeeding and shout about it. That will get you the initiation rates, but it won't get you the duration. And the weaknesses in legislation are because of industry lobbying. We have to be really careful about that. This is IPFAN's World Breastfeeding Trends Initiative, and they track all these the countries and what their codes are, all their policies. It's really important to keep track on that. This is actually 2020, but individual countries do that as well. But first, now I want to very quickly go through how we got to where we are in the EU, and to remember the importance of the democratic procedures. Speaking as the UK, I'm devastated that we're out of the EU, and I had nothing I can do about it. But I just wanted to give credit to the MEPs that pushed for the code in Europe. So very quickly, 81, all EU member states endorse the code. In 82, the Commission proposes an industry code. This is how things happen, saying, and one of his staff saying, no proof that advertising undermines breastfeeding. Then he proposes this industry code. The MEPs reject it, and then they keep voting for the international code. Then they vote in 86, 33 amendments. Lord Cofield accepts them. Then you have he accepts that the directive's aim is to protect health. That's terribly important. It wasn't. In the beginning, it was seen by the Commission as a way to expand the market, because we always have this dilemma where you have a conflict at the heart. The Commission's role was to expand the market. And of course, we mustn't blame them. That's what populations want. They want your governments to expand and make more money. So the health and all the human rights objectives that we have are often in conflict with that. And the infant feeding issues is right at the heart of this. In 91, the Commission accepted that the aim was to protect health, and then a new clause was put in 91, allowing the prohibition of advertising. It wasn't in there. We had a big row with the Commission, and journalists helped us actually prove that you had to allow member states to do what was right, and they should not be conflicting with the international code. That we were very, very insistent on this, that maybe the EU directive didn't go far enough, maybe it didn't do everything that the international code, but it shouldn't conflict. So in 92, the export directive was adopted. That's incredibly important, and really, because the EU, as somebody else has said, has a huge influence. I mean, I think something like 60 or 70% of the formulas coming into Africa are from the EU. So we have a huge responsibility for actually making sure that our products are safe and that actually they're marketed properly in the right languages. So this was work that we did there. But I want to come now very quickly to the Scientific Committee for Food. In 2000, we exposed the fact the Scientific Committee for Food had doctors who were not declaring their interests. We exposed it. The next slide will show you, but EFSA was created then, and DG Santa took over from DG Industry. We had to complain because actually the person from DG Industry came over to DG Santa. So we had to take him to the Ombudsman and complain. After that, he behaved rather much better. 2011, MEPs voted on a claim for optional ingredients. I won't have time to do this because there's so much in the history, but the MEPs have been there voting for sugar reductions and other things. The EU Commission behaved much better in Codex and the international trade or places that we go to after we dealt with this conflict of interest. Here is some of the press coverage we got. It was just a few of us clinicians, and we just sort of like pushed and said, you have to declare your interests. So when this was closed down, the Scientific Committee for Food, because this one doctor would not declare his interests. And so then the Commission agreed that actually they should have a scientific committee that protected the EU, that was separate from the political influence. Excellent idea. And after that, the MEPs went on to do all sorts of things. Here they are stopping the optional ingredients on DHA claims. This is a briefing we had. Really, this is at the center of the contaminant story now, this optional ingredient, the ARAO. This one was about the DHA claim. We should not be able to make a claim on what is an optional ingredient. If it's important, then it should be in all formulas and no claims made. These are more about what the MEPs were doing. But I want to come quickly now up to EU transparency and conflicts of interest and why it's important. The Codex Alimentarius is hugely important, and a lot of people don't realize that there was a standard in 1987 adopted by Codex Alimentarius, and it has no safeguards regarding marketing, sugar, or other key ingredients. Now, the Scientific Committee for Food member, Professor Jean Ray, was the key pediatric advisor at that time. So you see how all the way through from the 80s up, these same people do really harmful things. And this actually, when you have a Codex standard, you have real problems because that becomes the benchmark against which, I mean, countries can go further, but they face challenges, and they are challenged. There are hundreds of challenges with, about you're going further than you have to prove that this is necessary for your child health. So in 2023, we brought in a better Codex standard, and that means that countries can now prohibit follow-on formula marketing and widen the scope of their laws without fear of triggering costly challenges. Another conflict of interest here is the European Society for Gastroenterology and Nutrition, I can hardly say it, has 43% of its income from the baby food industry, and it's highly problematic. So during, just to bring us up to date, during a critical debate in Codex about follow-on formulas, ESPGHAN argued against a prohibition that was being the EU, UNICEF, WHO, Norway, I'm sure Norway, we were all saying, please, you can't have flavors like strawberry flavored growing up milk, which nobody wanted. Nobody wanted these formulas, the follow-on formulas. They're not necessary. The ultra-processed products, if the baby is not going to be breastfed, the infant formula can be used right up till 6 months, a year, and you don't need these other formulas. So, but this Bert Koletsko from ESPGHAN, he claimed that this would put products at a disadvantage to less good products that don't meet Codex standard. So then we couldn't get that in. Yep, am I only 1 minute?
Sorry to briefly interrupt, but we are nearing the end of the allotted time.
Okay. Yeah, okay, so I'll just quickly whiz through the digital marketing. This is showing you all the digital marketing. And you'd see how much it is. This is social marketing. So all we need now is a WHO resolution to call for independent oversight of manufacturers, independent monitoring, listen to whistleblowers, community-based milk banks, and full implementation of the code. And then the last key messages I want to say is we must keep policy setting free from commercial influence. Partnerships, by definition, are arrangements for shared governance with shared goals. Okay, so that I think that's fine now. I finished. Okay, sorry, I was a little bit over time. Okay, thanks very much.
Thank you so much, Patty, for your inspiring lecture.
I'll stop sharing now. Excellent.
So this has really been wondering, listening to all the presentations, and we have actually a few questions in the chat. Some of you might have been answering a little bit already directly in the chat, but it's good for everyone to hear the different questions. So there is first there is one question for Rollins. Hello, I would like to ask if there are any research on breastfeeding impact on type 1 diabetes in children, including the age of the manifestation of the type 1 diabetes.
Thanks, Hannah. So I'm not aware of any data about type 1 diabetes. Type 1 diabetes is the insulin deficiency that happens often, and young children present with this. So I don't know any data related to type 1 diabetes, and I think it's probably unlikely that because it's very much a genetically driven predisposition. So I don't know any data related to type 1 diabetes. So the preventive effect of breastfeeding relates to type 2 diabetes, which links with all the metabolic illness that we see associated with early overweight and obesity. But I think the prevalence of childhood obesity globally is massive, and type 2 diabetes, the impact of that in terms of drugs, it's certainly something that breastfeeding does impact on. Thanks, Sarah.
Thank you for that answer. There's also one question for Patty. Are there examples of countries that have introduced regulatory measures to restrict or govern direct or indirect industry funding of health professional and medical specialist training by breast milk substitute manufacturers?
Yes, I mean, there are countries. It is one of the most difficult things, and it's completely left out of the EU regulations. I mean, India, for example, also many Asian countries have it, but they don't. You can always find the fact that it's violated. That's the trouble with all these things. I would need to go back to my files and really check it through. But if you look, I can send you a link for these reports, because we go through point by point which countries do actually have decent controls, and making sure that the actual information, I mean, in the UK, we try to make sure that the information that the companies would not be able to give commercial information through the healthcare system, and that worked for a while. But they're just relentless, and it's got to be monitored. And everything we found when we're doing these analyses is that monitoring is actually critical, and the monitoring has to be independent as well. Governments must take that on as a very important thing to do. And of course, so many other things get in the way, and it doesn't get done. But it is really critical that it's independent. Otherwise, the companies will just step in and do it and tell you everything's hunky-dory and fine. I think, Nigel, you're wanting to say something on that. A country that actually does it?
No. I mean, I think there are countries that require health professionals to register gifts and donations. But that doesn't necessarily have consequence. But it is used, for example, in the current thing about the recalls of the formula milk. There was one report in a French newspaper where a pediatrician was diminishing the apparent health seriousness. But the journalist then looked at the register in France and found that this pediatrician was accepting gifts and donations from the company. So I think the registers are one important part, but I think Patty really is pointing to the bigger problem, is that there's very little monitoring, and even if there is monitoring, there's very little implementation or consequence. But the registers, there are registers, which I think is a good and important step.
Exactly. I think that's true, and we've got to remember that it's not a small thing to actually complain about something. I suppose, having run the Nestle boycott and everything, people wouldn't understand why just wearing a badge or refusing a lunch or whatever it is you want to do. It's big, actually, and it has an impact. And monitoring and reporting all has an impact. We just show policymakers that it really matters. So there are countries, and Brazil, all sorts of countries do this, and make sure that there is transparency. I think the Latin American countries are getting much more transparent and leading the way on that. So we really need to follow that. Okay, are there other messages? I think they were due. Monitoring. I know we used to, sorry, I've got lost now. We used to have do global reports all the time, but because we had a code monitoring in Penang, and we don't have enough resources to do this. IPFAN is completely independent and so very, very poor. So if anybody wants to support IPFAN groups, it's really, really welcome, because it's a lot of work, and it definitely needs support from people to actually make sure we continue this work. But we've yeah. Let's see.
Nigel, did you want to comment on this?
Yeah, actually, it's not exactly that one issue, but I know that we're just about to finish. I just want to really say really well done for organizing this webinar. But we are talking about things about children that we have been talking about for 50 years. Yeah. There's a really big opportunity that I think everybody needs to recognize. The nature of the evidence with respect to non-communicable diseases and the importance of breastfeeding for women has not really been part of the story to date. And there is something really powerful and significant in the data that we have. So it's very easy for the companies and so on to say that formula is the same for children. But the impact of breastfeeding for women's health, we really need to understand that as a really strong political tool and lever for mobilizing support for breastfeeding, and also for much stricter monitoring and implementation of the code. I think we really need to understand this issue about NCDs for women and children, but the NCD story for mothers, I think, is hugely important. So just thank you for the chance to
Thank you very
participate.
much for that last message, Nigel.
Totally agree. And there's plenty more on our websites, you know, about the contamination issue, which is getting worse and worse as we do. It's really, really important. And thank you, Norway, for raising it at the EB. It was excellent. Okay.
I really want to thank all the speakers for the excellent contributions, and to give the word to Anna and Angela.
Okay, so maybe I prepared a very short text, so I'm reading, and please complement as you wish. So thank you, Nigel, Julian, and Patty, for your really valuable input. And wow, we have a lot of work to do. So, and I think that this valuable presentation reminds us that protection from commercial determinants of health, the promotion through sound public policies, and the support of breastfeeding across all settings are not merely a matter of women and babies, but a cornerstone of future public health and non-communicable disease prevention. Considering this impact, including on cardiovascular diseases, as Nigel showed us, it is regrettable that the new European Cardiovascular Health Plan does not refer to breastfeeding or to this critical window of opportunity for lifelong health. This is something else that we need to work on. This joint action brings together more than 25 countries. We have work packages working very hard on policy and regulatory systems, as well as many of Europe's leading networks working in these fields. We are confident that through this joint effort and the collaboration that are emerging and will continue to develop, we will be able to maintain a strong focus on early infancy. And to people that joined us today for the meeting, you can follow our work on the implementation of the baby-friendly community and related initiatives on the Joint Action website, where you will also find the recording of this webinar. And also the updates on our activities are also shared regularly through the Joint Action communication channels and social media. And for those that are interested in our work, we remain available for further information and collaboration, so please feel free to join us. Anne, anything else?
No, just thank you to all of you.
Thanks
And
very much.
have a nice day and a nice weekend.
And
Goodbye.
help us get a new
Thank you
resolution
so
in.
much. We appreciate your participation.
Excellent. Thank you.
Thank you. Thank you.
Bye-bye.
Bye.
Okay.
Bye-bye.
Bye.
Bye-bye.